Hey, it's Dr. Rucker. I have a very good question today I'm going to answer. I'll probably write more information in the future in blog format. But the question is regarding someone who's a female in their late 30s. And the question is, if the LPA, lipoprotein A, is elevated, what would you do? The first slide I will review is some basic background regarding lipoprotein A. They have had some studies come out. What's funny is the conventional world is basically scratching their head about LPA, but maybe the integrative world has some good answers. As you will see, there's a lot of things the patient can do. High dose vitamin C is helpful, but I'm going to give some straightforward answers. I pulled this from a blog, or a medical site rather, and not that I agree with everything, but I redlined some interesting things. So yes, LPA levels that are elevated put the patient at an increased risk for heart disease. The level of LPA is determined by the patient's genetics. It's not seemingly affected by lifestyle, and especially doesn't seem to be affected by statins. I think that's why patients struggle, but then there are a lot of smart patients that don't want to take statins anyway. Next thing underlined is sometimes dietary consumption can affect LPA, but that's contradictory if your level is determined by your genes. Lifestyle or medications don't matter. Probably is the fat ingestion doesn't matter. Then they said the best treatment is to reduce the cholesterol burden with a statin. But that contradicts everything here. That's why I wrote, haha, okay. Genetic dyslipidemia affects nearly 1 in 5 individuals where the LPA is over 50 or even over 120 nanomoles. This is a highly atherogenic lipoprotein. That means it would cause a predisposition to create atherosclerosis, which would mean narrowing of the arteries, especially the coronary arteries. And there it says it builds up in the inner lining and it can cause formation of fatty plaques. Next slide, you can see here in this blog, they do mention vitamin C supplementation can help. So anyone doing IVC, they're on to a good path, but more needs to be done. So if I had an elevated LPA or one of my patients, you can see another thing that would make sense is the CAC is coronary arterial calcium score. So you need to look at your CAC, I believe. Extremely high CAC, elevated LPA puts a patient at a cumulative, I'm going to guess this is percent, cumulative incidence, so 20 in percent. So the peak would be a coronary arterial calcium score that's elevated. So you can see this is an independent risk factor. Even if your LPA is not elevated, you have a 15% incidence. And that's over a 2 and 3% incidence when you have a 0 score and a non-elevated LPA. But look how low the elevated LPA incidence of coronary disease is if you have an elevated LPA but a 0 calcium score. So the reason I'm showing you this is I think a baseline coronary calcium score would make a lot of sense for a patient that wants to discern how deep their risk factor is. But as this presentation continues, I'm going to give you a solution for this problem. This is a slide that came from a study, MESA. I don't remember what that stands for, but they were looking at a lot of risk factors. So in this study, this was published in JAMA, it showed LPA does predict ASCVD, atherosclerotic cardiovascular disease. Over 50 could be an increased risk factor for white and Hispanic males. Over 30 could be for African Americans. So females, oh, they said white and Hispanic persons. Then we show that LPA is a strong predictor. It's even worse if you have diabetes mellitus. A recent meta-analysis, 8 combined studies showed a 38% higher risk of developing diabetes if you have the lowest LPA. That was just interesting. I don't find that. I don't know why I underlined that. LPA testing should maybe be done as a baseline once in all adults. Now, the conventional guys want to find more reasons. I believe they'll come up with some kind of crazy treatment, but I don't think that's crucial that they find an answer because their treatments often cause problems. This is a good slide. It shows all the different effects of lipoprotein A. Some of this is kind of physiologic, like or pathophysiology level. Who wants to talk about foam cells, necrotic core, or increased lesion calcification? But you have it to understand. Combine this with the inflammatory mediators and then also some mediators that cause formation of clot level, and that together would result in the problems that LPA elevated patients could have, such as plaques rupturing, leading to heart attacks, even strokes, aortic style stenosis, stenosis of bigger arteries in the leg. There's aortic valve stenosis. So it's a good slide showing the cascade that LPA is involved in. Here I'm doing a preview of an article coming up on calcium score. So the calcium score is a CT scan, non-contrast, and you can see moderate calcification. They actually show up. This patient has severe calcification. And this article will talk about how calcium score is almost a better indication than the cholesterol panel. So that's important for patients to realize, and statins have some negative side effects additionally. Here comes the interesting catch, which I will lead you into the solution that we're going to look at. This is a study where they were looking at, there are two different types of isoform, the LPA lipoprotein itself. 36 studies were looking at phenotypes. So they did as assessment of genetics, and then they did a breakdown of which type of LPA. They don't tell you that when they tell you LPA. So there's a low molecular weight and a high molecular weight. Well, the smaller isoform puts a patient at a twofold higher risk of coronary heart disease or stroke than the larger protein. So it's almost like the smaller one gets in there like little tiny BBs and causes more damage. So further studies are needed to determine whether the impact of the smaller isoform is independent from the LPA concentration. Well, most things are pointing to that the smaller isoform is the bad actor. So I'm going to give you the solution. Here's a slide from the Lancet. So lipoprotein A is resistant to most statins. See, statin use causes a drop in LDL cholesterol. No drop for lipoprotein A elevation patients. So conventional medicine is scratching its head. Trust me, the answer, conventional medicine doesn't know how to use it, is they use high-dose extended-release niacin. No, you need to use raw niacin. So in this study, they showed the niacin causes decline. They didn't even use the right niacin. Decline in elevated LPA levels in male subjects with low but not high molecular weight APO phenotype. So if you have the risky phenotype, that's the one you want to take niacin. And they said here, niacin is the only drug, not that it's a drug, with proven efficacy in lowering LPA. So if you have the high molecular weight LPA, you're not really at a risk as far as we can tell. So there's the answer. If you have an elevated LPA, if you have the bad type, it will actually drop by taking niacin. It's almost like a stress test for the type. Instead, they're saying you should go and get a phenotype. It's probably expensive, all that. So take niacin. If your LPA drops after using niacin properly, and on my blog I teach patients how to use niacin, and your LPA drops, you have the bad type and niacin help fix you. If your LPA doesn't drop, you have the high type anyway, and that's not the type that causes damage. And then if you want to prove that, you can get coronary calcium arterial scores to really look properly at the calcification buildup. I hope that helps, and please ask me any further questions. I will outline answers in my Substack, which is @HealthRadar. Thanks, Dr. Rucker here.